A 32-year-old woman presents to primary care provider due to psoriatic flare that worsened over past 2 days. Patient states that her psoriasis is normally that she recently developed controlled. She also complains of some fatigue and states that recently developed pain and tenderness in joints of her hand and right hand being more tender than left. Her hands are stiff and her fingers swell up. She attributes these changes to new job where she constantly uses her hand to manufacture cabinets. Physical examination revealed plaque and silvery scale on her elbows and knees. Distal joints of right hand are mildly swollen and nails on both hands appear pitted. Which of the following is most likely pathogenesis of a joint pain? Local invasive infection of joint space, repetitive injury, autoantibodies to Fc portion of IgG, deposits of crystal in joint space, release of TNF and activation of rank ligand pathway. This patient is having psoriasis, asymmetric joint pain, dactylitis, pitted nails. What is the diagnosis? Yes, so the diagnosis over here is psoriatic arthritis. And basically, what is dactylitis? In this question, if you read here, the distal joints, yeah, sometimes her fingers swell up. Swelling of finger basically means that she's having dactylitis. Okay, how does dactylitis, how is dactylitis put in question? It is basically they'll say that finger will swell up, so that is dactylitis. For you, I've collected a few images which are important here. So this is an image of psoriatic plaque, which is usually seen on knee. So if you remember in the previous question, I told you that lichen planus is seen on lower leg, psoriasis is seen on knee or elbow. So that is why I was saying that where do skin lesion appear? It is important to identify. Sometimes you might not remember anything, but you can guess the skin lesion depending on the position in which it is placed. Okay, so on knee or elbow, that is going to be psoriasis. On dorsal of wrist or on leg, it is going to be lichen planus. Next is pitted nails. Can you see small pits here? These small little lesion, or someone has taken, let's say, it looks like someone has taken needle and made some pits in your nail. So this is how pitted nails look like. It is important to remember pitted nails because in USMLE in general, there are very few things that are, there are very few conditions that are associated with nails basically. There is clubbing, there are pitted nails or things like that. So that's why like it might come up. Or if you do not understand the question, you can give a wild guess. So this is psoriatic arthritis. Psoriatic arthritis is seronegative spondyloarthropathy. Seronegative spondyloarthropathy means that it is negative for rheumatoid factor and other antibodies that are present in rheumatoid arthritis. This is what seronegative spondyloarthropathy, this term means. There are 4 conditions that are included in this kind of arthropathy. That is psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, or reactive arthritis. Ritter syndrome is also known as reactive arthritis. So there is this mnemonic called of pair. This mnemonic is also present in first aid. So basically these 4 conditions are come under umbrella of seronegative spondyloarthropathy, which means that there are no antibodies associated with rheumatoid arthritis in the serum. That is why it is known as seronegative spondyloarthropathy. Another important thing to remember about these 4 conditions is that they are associated with HLA-B27. Now the question was, so we made the diagnosis that this patient is having psoriatic arthritis. Now the question was, what is the pathogenesis? Now let's go through this. Local invasive infection of joint space. This is septic arthritis. Repetitive injury. This is osteoarthritis. Autoantibodies to Fc portion of IgG. This is rheumatoid arthritis. Deposition of crystals in joint space, this is gout. And release of TNF and activation of rank ligand pathway, this is typical of seronegative spondyloarthropathy. So basically you have to memorize this. You have to memorize that In seronegative spondyloarthropathy, there is increase in TNF, human necrotic factor, which stimulates rank ligand. If you know, this rank ligand kind of stimulates osteoclast, which leads to bone erosion, which leads to arthritis, as seen in this patient. To quickly summarize, there is psoriasis, there is arthritis, there is nail pitting. What you are going to diagnose, it is psoriatic arthritis. Psoriatic arthritis comes under larger umbrella of seronegative spondyloarthropathy, which includes four types of condition, for which the mnemonic is pair. And this is the pathophysiology of all seronegative spondyloarthropathy. Is psoriasis always associated with arthritis? No, only 10% of cases of psoriasis are associated with this kind of arthritis. So majority of psoriasis will not be associated with arthritis.
Thanks for watching. Please give a thumbs up and subscribe for more.